All right, so the first point is going to be upper, as a right lower extremity problem. The first needle is going to be on the contralateral or left upper 1/5 sensory. I will begin about 1 millimeter or 2 on the ipsilateral side to catch that sulcus effect. Okay, so I'm going to start here, and you need a certain perspective. I need to know that the end of the sensory line is down here. So if I'm up here like that, I'm going to miss it. Okay, so I'll insert it using the modified push that finger technique. Slip it, aiming here. A little bit of resistance there. I want to go a little bit deeper.
Before he went deeper, I felt an uncomfortable pushing. It wasn't terrible, but then when he dived deeper, there was no sensation of the needle advancing. It was really comfortable.
Okay, so I'm going to put the whole, let them do that.
Do the first two.
Okay. Now, I'll reinforce that with another along the sensory line, a little inferior and posterior. So I'll start here, insert my needle. Again, keeping in mind I'm aiming toward the end of the sensory line. Finding that loose connective tissue layer. I'm starting to get a little resistance there. And I'm going to just do that. Okay, so that reinforces the first one.
Do a little twiddle.
And I'll twiddle both of them after I've inserted them. Okay? All right. Now, you want them to do this?
Yes, I want them to do this.
Do these two on your partners and the
For body points needled, especially when someone is treated for the first time, especially when the patient is treated seated. So be aware of sweating, chilliness, a sensation of nausea, sensation of goofiness or stupidity, or anything that's wet, cold, clammy. Let your patient know that he should not be brave. If he's any way feeling strange, let you know right away. Check, and lie the patient down if you sense that there's a vagal episode happening or about to happen. You shouldn't be brave. Your patient shouldn't be brave. Don't play around with it. Rarely does anything serious happen from a vagal episode, but don't be silly. At the moment, I'm the expert for a chiropractor who is doing dry needling on a 78-year-old patient, seated at the edge of a treatment table, like 20 needles in her back. She got lightheaded. She called. There was no way to communicate with the outside world. She fell back, jammed the needles into her back, and fell off the table, cracking her head, getting a small skull fracture and cervical fracture. I mean, it's just stupidity. It's bad training and basic physiological stupidity that allowed that to happen, which is one of my issues with the whole dry needling movement, is that you're giving people tools without their having the basic medical skills to understand how to use them. I'll end that. But do remember that needle shock is a real possibility for this particular treatment. So we're going to do the next two needles, contralateral motor, followed by ipsilateral sensory.
All right, so we're going to do the upper 1/5 motor on the contralateral side. Again, I want to start 1 millimeter or 2 on the ipsilateral side, keeping in mind the end of the motor line. So here's the top of the motor line. I'll insert and keep my aim toward the...
And notice how he has his middle finger supporting the needle and has a nice twist on it so it doesn't flop around and get out of control. Until he started twiddling the needle at the final end, I literally didn't feel it. I felt his fingertips, but I didn't feel the needle going in or being advanced.
Okay, we'll turn it on to the next one.
Yep.
Okay, then the next one is going to be the ipsilateral upper 1/5 sensory.
Now that you've gotten your patient as low as possible on his starting pain score, what is your final step? Foot motor sensory. Foot motor sensory, you enter 1 centimeter lateral to the midline marker and thread it back parallel to the sagittal midline as far as you can go through the motor territory, then the sensory territory. It looks like this, and that's what you're going to do now. So you have basically the head should look somewhat like this when you're done. At this point, you may take out all of the, excuse me, after you put in the foot motor sensory or start the foot motor sensory, and you know where the midline marker is, you may take all the other marker needles out, or take the marker needles out except for the midline if they're in any way bothering you or the patient. All right, foot motor sensory.
Here's the midline marker. I go out 1 centimeter. The width of my little fingernail is 1 centimeter. I start at the midpoint, insert my needle, and then just look at that.
Again, notice how he's got his middle finger supporting the needle all the way. That's one of the toughest things to train your fingers to do. It's to support it so that it doesn't buckle. And I felt that, but it wasn't anything that I'd complain about.
Yeah, I felt resistance when I was about a third of the way in. All right, then on the left side, or the contralateral side, 1 centimeter out, on the midpoint, insert the needle. Less resistance here.
That was easier than the other side.
There was less resistance. Okay, I'll twiddle in. And Bob's your uncle.
There you go. Bob's your uncle.
Okay?
All right. Do it. The last step.
What's the last step? Yes. Everybody's taking off. All right, there's no particular sequence taking it out. So I'll start with foot motor sensory. Have my handy dandy cotton ball here, bleeding a bit. Thank you. All right, I'll do the other foot motor sensory.
That first one coming out hurt more than going in. So just be aware that you need to use your non-dominant hand to support the skin around it, and don't be surprised if the patient growls. And the patient growls.
Then I'll put in take out the contralateral motor. 340. Last one was, right? I need more cotton.
It's good blood, Alan.
I know, it's good blood. I need good cotton balls for the good blood. Well, how's that? Is that good right there?
On the scalp.
Hey, one didn't bleed. Good. I thought it was more than a legend. Not that big a deal. How's that? Okay. All right, so there you have it. Scalp often bleeds. This is not unusual. Warm weather, the person's taking an anticoagulant. This isn't having. Anticoagulants are not a contraindication for scalp. And, just have a cotton ball handy to mop up any blood that you need. All right. And in this case, we did have to do a little mopping. Any questions about that? Okay.
The guarantee for bleeding is not having a cotton ball in your hand when you take out the first needle.
Right.
Needles out. Gently. Have it done to yourself, do it to other people, get feedback so that you understand both the favorable and unfavorable consequences of your work. Go.
Sometimes when you would hit resistance, instead of just pushing through it, because I feel like it never got better once you hit it.
Good point.
Just
So
redirect.
exactly. Once you hit that rubbery resistance, back out rather than pushing. It cuts down on the discomfort and allows you to slide deeper and get into the good area. Fine. So you had that happen a couple of times. As the receiver or as the provider?
Probably both.
Okay. All right. Good lesson. Other experiences. Again, this is good, bad, or otherwise time.
Listen to your patient. They tell you there's pain or resistance, back up and start.
Listen to your patient. If they tell you there's resistance, back up and restart. But that starts by your telling your patient to stay in touch with you. You'll feel the needle going in, but probably you'll feel more my fingertips. If you're getting a discomfort, if you're feeling something that's pushing against what I'm trying to do, let me know right away. When you're stuck in the aponeurosis, your patient starts feeling the needle. Otherwise, you should be able to slide it. You should all have had that effect by now. You should be able to slide it without any resistance and without any special sensation as a patient. Fine. And likewise, prepare them that if you're leaving the needles in for a half hour or sending them home with the needles in place for 4 or 5 hours, let them know that as they wiggle their forehead or move their ears around, they're going to feel some tugging because they're pegged down. That's okay. That they should just cut back on that kind of activity until the needles come out. Other unpleasant events, unpleasant sensations that I'd like brought out. You're not betraying friendship or loyalty. I just want to hear what was less than you as a patient would have preferred not to feel. Or could it have been the turning of the needle? Did most of you get to remember to turn the needles when they were in place? Be very careful when you do that, because if inadvertently when you're turning, you're advancing it and you're grabbing those connective tissue fibers as you're turning it, that creates a discomfort that you don't need to have if you just keep it in neutral, anchor it, keep it in neutral, and even gently pull back a bit, not yank it out, but just put a little bit of backward tension on it. That will cut down on the stimulation discomfort, the turning discomfort. Speak.
I think finding the right angle is the challenge for me. I kept, starting at the 30 degree, and then it seems like if you stay at what you think is 30 degrees, you're going in too deep, and so I you have to take it.
Okay.
So starting out at 30, and then I was palate and then almost flatten the needle out.
Right. Once you start it, flatten it, but you get the flattening to try to run it parallel to the scalp is difficult, which is why the torque on it with the middle finger underneath it gives you that control of running it just under the aponeurosis. Okay. Say something. And decide from there whether to tilt it up or down. Good. Good.
My non-dominant hand, my index finger over the area of the insertion and applying downward pressure is helpful in the hand.
So you're resting your finger over the area overlying the area that the needle's tunneling. But not too much pressure so that you're not blocking it or creating additional resistance.
More of just the counter pressure on the skin.
Good, good, fine. Either right on top or on two sides of the needle track. Nice.
I'd say a couple of times the two that were hardest for me, I think, didn't get deep enough on my initial foot.
Mm-hmm.
So something I was kind of working on at the end, the last couple of minutes, smoother, but not getting quite deep enough into that situation.
Right. As with anything in medicine, especially acupuncture, the more you do it, the more quickly you get comfortable with it. If you have the opportunity to do this 10 times this week, you'll be, I'm not going to say masters, but you'll be comfortable by the end of the week. So that's the way it works. And your 10th liver biopsy is a piece of cake. One more comment.
So we're doing the sensory, making sure that the full 1 centimeter lateral to that.
Oh, did you start a bit inside?
Just a little bit, and it was enough to catch that really.
Yeah, okay.
Progressive.
Okay, good. How about our newcomer, Trevisan? Comment.
I don't know. So, I don't think I have anything else to say.
All right, I won't push. Fine, so this is just sharing experiences, good, bad, and otherwise, lets you get comfortable with what you're doing, makes your patients more comfortable when you're working with them. We're going to take a break, and during that time, I want you to think about anything that in class, because we've got a couple more hours, in class could be treated with scalp, so that you could have the experience of, does it make a difference or not? And of equal importance, think of the first 2 patients you're going to see when you go into clinic on Monday and Tuesday that would probably benefit from scalp as the first approach. So that we can talk about them, talk through the cases, decide how best to address them. With that under control, then yes, right, and that's all I'm going to say about them. The reason being that those are official somatotopic points for gut stuff. The Chinese did that for purposes of completion. I rarely use them. Jason Howe rarely uses them. They would be 3rd or 4th tier approach for problems taking place with the internal organs. So we just don't spend any time with it. Know that they're there if ever you're stuck and you need a lifesaver. The others, we're not going to spend time today on chorea tremor, nor on cardiovascular, nor on the speech areas. Those are more complicated rehab. We do want you to be familiar, and we'll do this after break, with the hearing vertigo line and the balance line, because with your TBI patients, you get a lot of disequilibrium issues. So one is vertigo, the other is balance. Vision, you know where it is. It's used for any vision problems. But again, for getting started with scalp here and now, we'll concentrate on just those. Then we have two other trauma spectrum add-ons that we created that can be quite effective to work in collaboration with ATP for stress, pain, post-traumatic stress, and intrusive memories, hypervigilance, focus problems, that kind of thing. So we'll give you those. We want those under control before the end of the day. All right, we have enough time.